welcome to ESC TV. Today we're talking about the Hotlines to Late-Breaking Clinical Trial session. We're lucky to have with us today Dr. David Wald from the Wolfson Institute of Preventive Medicine at Barts and the London School of Medicine. Dr. Wald, welcome. Now you're presenting data from the Preventive Angioplasty and Myocardial Infarction trial, or PRAMI. Perhaps we could start by talking at the hypothesis and what you were trying to look at with the study.
Thank you. The background to this is well known. The treatment of patients with acute ST elevation myocardial infarction is well established. It involves identifying the occluded artery that's causing the infarction and performing an emergency PCI. At the time of doing the angiogram, it's common to find other arteries that were not the cause of the infarction, so-called non-infarct arteries or non-culprit arteries. Whether or not we should proceed to treat those at the same time is unknown. In fact, there is a lack of evidence to guide us in this area. And for this reason, we set out to do a trial to really resolve that if we could. And the trial, as you said, was called the Preventive Angioplasty and Myocardial Infarction trial. We used the term preventive angioplasty because if one performs an angioplasty on a non-infarct artery that's got a stenosis, one's really doing it with a view to preventing some future serious cardiac event. But of course, there's uncertainty over whether that will or will not be effective.
Mm-hmm. And so what were your sort of primary findings from this study?
Well, the primary outcome was a composite outcome of cardiac death, a non-fatal myocardial infarction, or refractory angina. That was angina that's resistant to medical therapy, supported by objective evidence of ischemia. The outcome was actually quite clear. There were approximately 50 events in the group that were randomized not to receive preventive angioplasty or preventive PCI, and less than half that number in the group that did receive preventive PCI. That results in about a 2/3, in fact a 65% risk reduction, and that result was really very highly statistically significant.
Now, from what you're saying, it sounds like this is a fairly safe bet population for preventive angioplasty. Do you think that these findings are specific to this population that you studied, or do you think it has more wider implications?
I think the term safe bet was certainly not one we would have used at the start of this trial. In fact, the current recommendations for treating patients with acute ST elevation myocardial infarction is to limit the treatment to the infarct artery. And indeed, until the results of this trial were known, that was my practice. So I don't think anyone would have called it a safe bet that this is a population in which this would be effective. There was concern that there may be additional risks to extending a procedure using PCI in a patient that's already relatively unstable because they're having a myocardial infarction. In answer to your question, I think that these results relate to patients with acute ST elevation myocardial infarction. It would be wrong to extend the results to other groups, for example, patients with stable angina. Indeed, the results of previous trials in that group of patients do not show that a preventive approach to PCI is useful.
ESC Congress 365 is your free access to ESC Congress content all year long.